morning, good afternoon, good evening to everybody who's on the Zoom with us today. I'm Harriet Sachs. I'm the volunteer moderator for our patient chat. And we have been meeting since 2014 every month. So we're going on something like 90 meetings, looking at problems, sharing workarounds, sharing questions, sharing discoveries. Tonight, our session is very, very special. We have Dr. Melissa Reigle with us. And Dr. Reigle is a board certified urologist who's practicing in the Cleveland area. She's been in practice for 23 years. She graduated from Case Western Reserve Medical School, and she continued her specialty and subspecialty training through Case Western. I don't want to take our valuable time by talking more about her wonderful credentials. What I would like to do is hand off the mic to Jerry, who is the spouse of one of our patients. And Jerry brought Dr. Reigle to our attention because he said she was a very, very special support person in the life of his wife, who has APBD, and himself. So I'm going to step back and I'm going to ask Jerry to open the floor.
Try not to embarrass her too much, but Dr. Reigle helped change our lives in a variety of ways. One of us was convincing us, after trying pills and other ways to limit UTIs, to have the procedure for a suprapubic catheter. Prior to that, Marlene had multiple UTIs, was in the hospital for days, and then had to go to rehab. This allowed us to have a life where Marlene was not concerned about going out, having accidents, dirty clothes, and just embarrassing herself. And we avoided UTIs for over 2 years. That's one side of Dr. Reigle. The other side is her patients, in dealing with her patients and how she cares about them. Marlene was getting dehydrated many times, and Dr. Reigle suggested a procedure. And when our internist did not want to take over, our new internist did not want to take over responsibility, she stepped up and did it. And I can't thank her enough for doing that. And in an effort to make her life easier and avoid seeing us so often, she trained me on how to take care of the catheter. So that is one thing that has worked. And she is also the type of doctor that other doctors can learn from on her bedside manner. And I appreciate you coming and doing this for us. Thank you.
So as you all know, I have been emailing you for the last 10 days to remind you of this evening. And we have a number of people who chose to send their questions to me. So from a female patient, Dr. Reigle, she writes, I've recently had many, many UTIs and lots of symptoms and positive cultures. Indeed, 4 positive cultures in the first 4 months of 2021. So none responded to treatment, even though they appear to be sensitive to various medications when they're cultured. Doctors told me to stop testing because I am, quote, colonized. So what does it mean to be colonized? Is there something that can be done? Is this going to harm my kidneys? I am in pain. I am incontinent. I have more pain. What do you think?
Okay, thank you for that question. There are a lot of very important points that have been brought up in this particular question. Some of this might cross over into some of the coming questions as well. The first comment that I'm going to address is the comment about colonized. The way to consider bacteria live everywhere on the body, except for a few places are considered sterile. We have bacteria in our skin, bacteria in our mouth, bacteria in our ears, our navel, our tear ducts, all have bacteria living there in balance. And in that balance, they're not overwhelming. They're not invasive. They're not getting to us and creating a problem and inflammation. They're living there happily. That would be considered colonized. They live there in a colony. They live there in a colony of equal balance. When bacteria get into other organs that they're not supposed to be in, so for example, the bladder is considered sterile. Other organs are considered sterile, but the bladder in particular, bacteria can march up into the bladder, literally march into the bladder and set up camp. When they set up camp and attach and stick to the lining of the bladder, they will reproduce. When they reproduce, they release a toxin. The toxin is what gives you the symptoms of discomfort. It's what gives you pain, burning, frequency, urgency, and it can even be significant toxin that can make you have a change in mental status, weakness. Very often people have bladder infections that the standard symptoms aren't interpreted, and then they're so sick, or they look so ill that people think they may have had a stroke. We've had many people who have been ruled out for stroke in the hospital when ultimately they've had a bladder infection because of the profound changes that occur with the release of the toxin. So you go from a colonized area where bacteria are happy and living equally to actively growing and actively being aggressive and releasing toxins. That would be considered infection. Some people have such chronic bacterial load in their urinary tract, in their bladders, that they become transitioned over to colonized. And what I mean by that is that the bacteria are no longer aggressively reproducing, but they're living there pretty equally. And if you are to culture the urine, they will show bacteria. However, it's not releasing toxins and creating great illness. So there are some people who have bacteria in their urine all the time and are just not symptomatic from this. Now, in your particular question, that would be a colonized bladder. In your particular question, you asked about, you asked about this situation, and you also commented that you're in pain and incontinence. So I'm going to presume the pain is active infection and release of toxin. Incontinence may or may not be from that particular infection, because there's lots of other reasons in this disease state and other states that you can have leakage. But for me, it sounds like you do have active infection. The problem is, in people with this condition, they don't tend to empty their bladders efficiently, and or because of the leakage, they're always wet and very uncomfortable from that. And so that in of itself anatomically is setting up a situation in which bacteria thrive. And so you're more prone to infection just based on the disease itself. I hope that answers your question.
So is there anything that she should be looking at?
Okay, so getting back to the anatomy portion of it, my biggest concern is, are you in fact emptying your bladder to completion and efficiently? And if you're carrying around a large volume of residual urine that is not emptying out, that creates a stagnant pond. In other words, the bacteria love that. They like a dark, moist, wet environment. Well, that's the bladder. And then they have opportunity and they reproduce. So if you're carrying a large residual volume of urine in the bladder, what I mean by that is more than 2 ounces after you've already urinated, if that stays in your bladder, then you are going to have a very hard time clearing the bacteria from the infection. Whether you use appropriate antibiotics or not, it's like a stagnant pond. It's stagnant urine sitting there that gets junky.
Great. So that leads to the next question. How does that residual urine, let's assume it's there. How does it?
Wait, can I say something?
Sure.
Sorry. Can you all hear me?
Yes, go ahead.
Okay, great. I would like to say that the urologist, several urologists have checked me on a number of occasions, and I am emptying my bladder. So there isn't residual urine there. And I guess my question is this going to harm my kidneys? Is it going to go away? What can I do?
So if it's colonized, presume it will not go away. Will it harm your kidneys? If bacteria march in a way from the bladder up to the kidneys, and that can happen when the bladder, again, doesn't empty efficiently, or if there's a condition, an anatomic condition called reflux in the kidneys. But most of the time, we don't have that anatomic condition that most of the time we're born where the urine comes down from the kidneys directionally into the bladder and doesn't wash backwards. So if you are emptying okay and you don't have reflux, the likelihood of it going to the kidneys is low, and likelihood of it affecting your kidneys is low.
Okay. Is there anything that I can do?
Yeah, that's there, and that's an interesting it's an interesting question. That there's a lot of steps to preventative strategies, and the basic prevention strategies are to make the bladder not welcoming to the bacteria. That includes significant hydration. Jerry had alluded to a comment about hydration. One of the tough things to accomplish is good hydration, depending on how advanced the disease process is. And so if someone is suffering with recurrent infections, I ask they strive for 6 to 8 8-ounce glasses of water a day. That's a lot of water. And I don't mean other beverages, I mean water. 6 to 8 glasses, 8 ounces each, is tough to get in, but it mechanically washes the bladder and dilutes things out. The second strategy, there are 2 vitamins that are known to adhere to the receptors in the bladder that the bacteria can stick to. Specifically, vitamin C and cranberry vitamin. Those 2 things are excreted in the urinary tract. When you take them, they're processed through the kidneys and excreted, and they will bind up those proteins that bacteria stick to. And so if the bacteria don't have proteins available to Velcro onto and to stick to, they're more likely to wash out when you do in fact void. You want to urinate on a very timed and routine basis during the daytime hours, no longer than every 2 hours. Should you be going to the bathroom, you shouldn't be holding it longer. And also real good bowel regimen so that you don't suffer with constipation or diarrhea. Those are good early prevention strategies that you have to live by every day of your life for prevention. Beyond that, people ask me, well, can't I just go on a low preventative dose of an antibiotic every day? That there's definitely folly in doing that, because then you start to select out bacteria that develop resistance to those particular antibiotics. You're hearing a lot on the news about coronavirus developing changes and mutations. Well, bacteria mutate even within an individual, and they mutate pretty quickly to become strong enough to survive the different antibiotics. The same bacteria have been around for forever, and we haven't eradicated them. They just continue to evolve a little bit. And as they evolve, they develop resistance to different antibiotics. So a preventative low dose of antibiotic, I don't necessarily recommend.
How much vitamin C would you recommend taking every day? 500
milligrams a day. And going back to the cranberry vitamin, the dose of that isn't necessarily set in stone, but and I want to be very clear that it's not cranberry juice. It's cranberry vitamin, or actually raw cranberries. It's the skin of the cranberry, which contains an element which is called a phytokine. And phytokines are an element in the skin, which are the element that adheres to the bladder lining. And you can either get them in a vitamin, which is the easiest way to take it, or you can eat raw cranberries. Well, that's not so easy to do. It's terrible for your teeth to eat raw cranberries as well. So we would suggest the cranberry vitamin, and 1 to 2 of those a day is agreeable.
I've been taking 1,000 milligrams of vitamin C for years. Is that too much?
Well, vitamin C, the reason behind the 500 milligrams is you can absorb daily about 200 milligrams, and then you start to excrete it. And when you excrete it through the urinary tract, it will then be available, as I was saying, within the bladder. The problem is, if you go much higher than 500, you can be more prone to developing kidney stones. So there's a balance there, that more is good, too much is bad.
Got it.
Great. I would like to move on to our next question. We now have a great backlog of them since we
All right.
got things started.
I'm sure as we answer them, they
Oh,
start to bring
Oh,
up more
they
things.
sure are. All the
Yeah.
great ones have come in. I'd like to turn it over to Bruce, who's going to ask a question verbally.
I am. Hi, and thank you all for presenting this. This is wonderfully informative. We have I had a general so I sent this to Harriet earlier today. I have 8 bullet points and I added 2 today, and it deals primarily with suprapubic catheter. Jennifer, my bride of 32 years, has been diagnosed with APBD and has had nothing but issues with her bladder for the past, I don't know, 4 or 5 years. She also had a mesh installation 10 years ago that had to be undone. And so there was a lot of concern about what was the cause of her urinary problems. But right now we're suspecting it's mostly the APBD. I did have a general question on why is the bladder impacted by APBD? But the others deal with the suprapubic, because Jennifer is as one would expect, has some apprehension regarding adopting a suprapubic. And we're working through UCLA, which is a great technical, powerhouse of medical stuff. But when it comes to the softer side, then not so much. So we get a lot of technical, wonderful information, but when it comes to, and how do we handle this? And it's kind of like, well, you'll find out as time goes on, or we kind of get moved along. So the first was, why does the APD, and the rest are really the suprapubic. Specifically, a question is, when you have a suprapubic catheter, does the urge to urinate go away? Yes, no. When you do have a suprapubic catheter, is there any leakage through the urethra? When you do have a suprapubic catheter, is there any leakage around the catheter site? So I'm kind of curious just about the cleanliness and the hygiene and how that works. So those are those questions. Jennifer has.
Bruce, can I interrupt you and start to answer some of this? Because I have a sense I'm going to lose sight of some of the details. And I'm gonna first start with the question of why does APB, why does it affect the bladder? It doesn't affect just the bladder. It affects, as you guys, I'm singing to the choir, it affects everything. The bladder is an organ that has such complex neurologic integration in order to function appropriately. I'm going to tell you a little, just the very, bladder 101 basics of physiology and how it works. And then you're going to be able to understand how each component of how it works can be interrupted by the disease. So the basics of it is this: the kidneys filter the blood. The waste product is urine, and the urine is propelled down from the kidneys into the tubes, the ureters, and enter the bladder. As it's propelled down literally in small squeezing bursts. We do not feel those small squeezing bursts, and we don't feel the urine entering into the bladder in little few millimeter increments, both from the left and the right side. What we feel is the bladder starting to fill, and as it starts to fill, the muscle fibers of the bladder, it's a dome. It's shaped like a dome. And so think about a balloon. And as the balloon starts to fill, the spinal cord nerves sense the stretch of the muscle fiber. It sends a signal from the surface of the bladder up the nerve to the spinal column. There's a transition station there where it basically regulates it almost like a train station and sends that signal up the spinal cord to tell the brain, hey, I'm starting to stretch. The brain says, wait a second, you're not at the bathroom. You better not squeeze down inappropriately. And that stretch then actually lengthens a little bit more. It sends a signal back down the spinal column to say, I'm not at the bathroom, you better lengthen a little more and get a little bigger. So that water balloon gets a little more lax instead of tense until it's time to go to the bathroom. And then you hit the bathroom, and when it's time to go, now the spinal cord says, squeeze that muscle fiber down, but the muscle fiber also has to not only squeeze down, but it has to also have the sphincter muscle open up and relax. So there's a contraction of one portion and a relaxation of the other. And then we evacuate and we're done. and then the sphincter closes and the bladder is relaxed again. So that's normal. So you can appreciate all those reasons why that can go wrong. And so every aspect of that can go wrong. Now I'm going to move that from that normal physiology to answer the very specific suprapubic tube questions. So as I described, the bladder shaped like a dome, it's like a water balloon. The suprapubic tube should be inserted from the abdominal wall into the dome of the bladder, or thereabouts the dome, the front wall, the top portion of the bladder. And as it goes in there and drains the bladder, it drains it from the top. Well, the bladder fills from the bottom down. So there you have to imagine that that vessel of the bladder has to be a little bit filled before the tube appropriately drains efficiently. There's still a wide open urethra, so you can get the path of least resistance. If that tube, the suprapubic tube, got blocked, you can have urine come out the urethra, just like it did before, because we don't sew that closed, we don't close it down. But with time, the body and the tube that goes in the top of the bladder, the suprapubic tube, it decreases the amount of muscle contraction where the tube inserts, and it relaxes, for lack of better words, around that tube a little bit. When it relaxes, it drains more efficiently. So the first few weeks after people have a suprapubic tube in, they tend to have some leakage, and that can be frustrating, but it usually is temporary. And as the body accommodates and relaxes, it drains efficiently through the suprapubic tube. If that tube gets kinked, if something happens, if the tube comes out, you still have the passageway of the urethra. The site at the skin where it inserts tends to, as the transition of the tissue heals, it creates a tract. That tract looks very much like the inner lining of your gum. It's sort of a bright pink tissue that tract creates. And sometimes that is gets a little irritated, much like people's gums will get irritated. And the best way to clean that is soap and water. And sometimes if it gets a little irritated, some peroxide. However, another thing that when anything is foreign body or anything is moist, yeast can grow. And so another really great trick is to dry that area with a hairdryer 1 or 2 times a day, after bathing and cleaning. And it really helps to keep moisture, aroma, yeast, anything from that tube site down. It really works beautifully. And most people tolerate that tube beautifully by doing that.
Okay.
Now, you had asked me about the site it goes into. You asked me about leakage and maintenance. Now, please go ahead with the rest of your questions. I'm sorry I interrupted you there. I had a lot to say.
No, this is very helpful. Gee, the last question I had was regarding urge, but I guess that goes to the dome. And if the dome doesn't get filled up enough, then it's not going to send the message up to the brain. So you might not have the urge to use the bathroom, but there might be leakage that happens collaterally.
Okay, so, but let me reference the urge a minute. If you do have urgency, there are medications too that can be utilized to decrease urgency in the face of a suprapubic tube. So if you have a tube put in and you're having quite a bit of leakage yet, then we add a medication to make the bladder muscle itself just a little bit more relaxed.
Okay. The type of catheter, latex versus silicone, we've been combing the internet to try to get more information regarding that. Is that really a conversation? Is it really a personal preference? And so that was one question. Another was, can you swim in a public swimming pool if you have a suprapubic catheter? And then the 2 questions Jennifer had was, will the procedure hurt, and how will she actually feel afterward? I did tell her, one of the YouTube videos I saw equated the suprapubic catheter as like wearing glasses or a hearing aid. It's a device to help you body function in an optimal manner. And so if you look at it that way, it makes your new device a little less foreign, I suppose, or at least something we can relate to, because we do have glasses. Yes. So those are the 3 questions.
Okay, so yes, you can swim with it in place. And what I would do with that is I would detach it from its drainage bag and place a plug in the tube. And thereby you don't have any worry about anyone seeing urine or the bag. It's just there. You can shower, you can bathe, etc. the question regarding latex versus silicone is a very interesting question, and you probably would have patients all over the board on how they would answer this. I can tell you I put in catheters probably 7 a day. All right. And the silicone is stiffer for sure. Latex is much softer, much more malleable. And thereby I would expect it would be more comfortable. However, some people are allergic to latex, and that silicone is a really wonderful alternative. Silicone catheters, so if you all understand how a catheter is designed, they're held in place by a balloon that you inflate. The balloon sits the tip of the catheter just past that, just beyond that balloon is the drainage port, but the balloon has 10 milliliters usually of fluid, which holds it in place and prevents the tube from slipping out. The silicone catheter balloons tend to have more defects. What I mean by that is they can get a pinhole from manufacturing in them where you put the tube in and the balloon doesn't inflate, or inflates poorly, or inflates and then deflates and falls out. That happens maybe, I don't know, one time out of hundreds of catheters, but it's more common in the silicone than it is in the latex. And those who have suprapubic tubes perhaps can weigh in and tell me what they feel their preferences are. But if you have allergy to latex or irritation from it, you just can't use it. You got to use the silicone. The other thing I want to comment about is with reference to infections. If you have a suprapubic tube in place and you're still getting infections, there is a tube which is silver impregnated, and that's a silicone tube. And the silver impregnated silicone tube really helps prevent bacteria from being there as well. There's something about the silver that makes the bacteria non-mobile. So it's something to consider. Those are very expensive catheters, but it's a lot cheaper than hospitalizations and antibiotics. So we talked about silicone, we talked about swimming and showering, and then you asked about the procedure itself.
Yeah, well,
so the procedure itself is done under anesthesia, right? And so you don't feel it going in, and in the recovery room, you're pretty comfortable. You might feel like you did 30 sit-ups is what the feeling is like. In other words, your stomach hurts a little bit in a muscle sense. Most people who have the procedure don't require any pain medication afterwards. In other words, Tylenol or Motrin is okay. And as it heals and seals and everything gets put into position, I leave that tube in for 4 weeks at least so that a tract is established. If the tube comes out or falls out before the 4 weeks, it has to be put in immediately, or that tract will seal up immediately. And then the procedure was done for nothing. I've had people who've presented to the emergency room after the tube fell out for whatever reason. And if it's been more than an hour, the tract can seal up. After a month, and after I have the patient come in so I can do the first tube change and instruct family if they want to learn. If they don't want to learn, I have them come in monthly to change it. But the tract develops pretty nicely. And if I take that tube out and I leave it out, that tract will be open for a couple days, but ultimately it'll seal down if there's nothing in there, and it'll seal where you don't leak any urine after a few days. So just keep in mind that tract is patent after a while, but it is not forever unless something's in there. Most people, your comment about the glasses, it was interesting. I would say, I think I would describe it more like more like a little bit more aggravating than glasses, probably more like if you're wearing an oral bridge or something like that, you can definitely feel it there. I mean, it's something, but it's very comfortable. If that makes any sense. Once
Over
it
time-
heals and yeah.
Over time, you just get used to either the pressure or its presence or
Yes.
whatever
But
feeling.
unlike glasses, if your glasses fall off, it doesn't hurt. If somebody inadvertently tugs on the tube, it hurts.
Great.
Okay.
And Bruce, with your permission, I'd like to invite some questions from our other guests. And then
Okay.
if we have some time, we can circle back. We have a quick one from the Q&A, and then I'll move to Harriet, which is what happens when you don't treat an infection?
Yeah, that's a good question. And some of it really kind of depends on how baseline healthy you are. I know that sounds quite vague, but there are some infections that with adequate hydration and vitamin C and cranberry vitamin, your body can get on top of, and you can pretty much clear up. That's in a pretty healthy person that can accomplish that, but sometimes they can clear up without requiring antibiotics. The folly in that is that at baseline in this condition, you are compromised. You're not healthy, so to speak. Your immune system is busy fighting a lot of other things. And so I feel like if there's active infection in this particular disease process, I think it should be treated. If not, what can happen? Can someone get septic? Can they get, yes, you could. I mean, and sepsis means that the toxin overwhelms and the bacteria can get into your bloodstream. And then from that, you can, as Jerry was pointing out earlier, you can be hospitalized. It can be a tough road. It can be a tough road.
Thank you, Dr. Reigle. We'll move to Harriet, who has a question from another guest.
From Germany, our gentleman chat friend writes, I have both urinary and fecal incontinence. The urinary problem is at an acceptable level of control, but the fecal incontinence is really the problem. Actually, it's a tremendous problem that involves mainly constipation. So his physician there in Germany is suggesting to implant a neurostimulator that will stimulate his sacral nerve. And the question is, could that be beneficial for his bladder muscles as well? Maybe could it be a negative to his bladder muscles? What are your thoughts on that?
All right, that's a very interesting question. And so there's a device which is made. There's a few companies that make it, but the main company that's done it for about 20 years is Medtronics, and it implants a battery operated. It looks like a pacemaker, and the leads go down to the sacral nerves, and the sacral nerves are responsible for bowel and bladder function, and also some sexual function. And so the idea is it will take like a pacemaker and give a rhythm of input into the nerves that come off of the sacral spine, and that will change the tone of the sphincters. So that being said, by changing that tone of the muscle, both at the anus and rectum and also at the urethra and the bladder, then you can do one of two things. It can improve continence and it can make it worse. And when that is implanted, you can change the pace and tweak it. And you can see when you turn up the electrode and give it a faster pace or a slower pace, how does that affect it? As a nerve is stimulated, it fires and then it has to recover. And the recovery time is just as important as the firing time. And that's part of how these structures work together. The muscles work with the nerves is by firing and then recovering. And so what this does is it acts like a pacemaker to alter that. Now, the interesting thing about that device is that generally the device is put in with an external test device first, where it goes into the spinal column, but the battery pack is not implanted. And so you test it and you see if it works. And if you get good success, then you go ahead and do the implant. So it's worth a trial, particularly with reference to the fecal issue, but keeping in mind that it can alter both for sure. And to speak to the fecal issue, certainly that is a huge portion, an upsetting portion and side effect of this problem. And so the constipation, and then followed sometimes by watery liquid stool, is extremely frustrating for patients and for people. So I appreciate where you're coming from, and it's interesting that that's the next stage for you.
Thank you.
For the next question, we're gonna go to one we received in the Q&A. I'll read it. This individual, this is a female. I've had months of UTIs and was put on multiple antibiotics. I am now on a low dose, 50 milligrams of maintenance dose for the past 4 months. I've had no UTIs, but what's your feeling about this approach? My sense is that I'll eventually become resistant to this antibiotic. Are there other options?
Wow, that sounds exactly like what I was talking about before. And specifically, the low dose maintenance concerns me, because I'm grateful that you've been infection-free for 4 months. That's fantastic. But I do believe that now that you've been infection-free for a while, it might be worthwhile to, now that you're infection-free, see where you stand using the prevention strategies that I was talking about before. Because ultimately, you may develop resistant bacteria. That's the biggest concern. And that's really, but to have 4 months of infection-free, I know it's really hard to say, hey, I'm just going to stop this and see what happens, because you're feeling pretty good right now, which is a bonus.
Great.
It's interesting how that question parlays off one of the first questions.
Mm-hmm. Yeah. We have one more I'll read in the Q&A, and then Harriet, I'll go back to you. For a neurogenic bladder, is the suprapubic catheter an option for males as well as females rather than self-catheterizing? Also, do they perform a uterostomy rather than self-cath? Are there medications for the neurogenic bladder better than baclofen?
Okay, so there's a lot of elements to that question. So the first thing is absolutely suprapubic tubes are useful for men. It's a very nice way to avoid the urethral catheter. And also, if intermittent catheterization is currently being used, which means sliding a catheter in, draining the bladder of residual urine, and then sliding it out. So if you're going to drain your bladder, you can do the intermittent catheterization, slide it in, slide it out, 4 or 5 times a day. You can do an indwelling catheter through the native urine channel for men going through the penis, for women through the urethra, which sits just inside the vaginal opening, or the third being the suprapubic tube. So most men with reference to the urethral catheter are pretty unhappy because it's uncomfortable. And it is, it has to, whether you're doing self-cath or you're having it changed monthly, it is a little bit difficult in the masculine portion of it. With the suprapubic tube in place and the penis then free, sexual activity is a lot more agreeable. It just kind of frees things up and is more comfortable.
Great. Thank you. Oh, and then the last one was medications for neurogenic bladder better than baclofen.
Oh, yeah. So there's a lot of bladder medications available. Baclofen is primarily used in people who struggle with muscle spasms as well, not just related to the bladder. It's a great muscle relaxer. It's very commonly used in people in particular if they have spinal cord injuries. And so it's excellent for that. But there are a whole host of bladder medications which are useful for neurogenic bladders if the bladder is being drained by some means. Everything from oxybutynin to Toviaz and Detrol and Vesicare and Enablax, Sanctura. Those are all some brand names. Myrbetriq, and there's a new one on the market, Gemtesa. Those are all bladder medications specifically. There are some medications that are not considered bladder medications specifically, but are used and kind of off-label. Amitriptyline, which is an antidepressant, when you use it at very low doses, not doses that can affect mood, but they will have effect on the bladder. Some of the muscle relaxers, as you point out, baclofen and the whole class of muscle relaxers can have effect on the bladder. So hopefully that gives you a little idea on some of the medications available.
Great, thank you. Harriet, over to you.
From a male patient, I get up every hour and a half to go to the bathroom at night, and even then I'll have floods. Besides, it's a two-part. Besides avoiding liquids after 7 p.m., what can I do? The Depends leak. I'm changing the bed. Do you have ideas?
So for men, this can be even more complex because you don't have just the neurogenic component, you also have the prostate. And in general, the prostate can cause issues with getting up at night, leaking, urgency frequency, poor force of stream, irritative voiding symptoms in general. But one of the first things that people see as the prostate enlarges is specifically getting up at night. There's another medical condition and is highly linked to nighttime, and that is sleep apnea. If there's any element whatsoever of sleep apnea, specifically what ends up happening with sleep apnea is the oxygen levels decrease at night. When the oxygen levels drop into the range below 90%, the body kicks in with creating a tremendous amount of urine output at night. When it does that, it's almost impossible to hold on to all that urine. And so there's getting up frequently, and in addition to also bedwetting. So sleep apnea might have a link to it as well. So there's a couple other components that could be going on, not just the disease process. So what other element other than Depends? There is a device which is very helpful for men in this case, and that's something called a condom catheter. I don't know if you've ever seen it, but basically it's a male condom that is then attached to a device, a drainage device. So you just roll the condom on and then it drains specifically into a bag and it keeps you dry at night. Very nice way to do it at night. There's a newer device for women, which is kind of interesting too for nighttime. And I don't know if you guys have heard about it. It's called PureWick. And basically it looks, for lack of better words, it looks like a white banana. And it is a device that's worn at night, and it is tucked in between the female labia. And for women who leak at night, what it does is it then wicks away the urine, and it wicks it away from the skin, and it draws it into a bag or a container at the bedside. And then anything that leaks at night, and the skin stays dry, and the skin stays much better and intact, and without getting wetness or skin irritation or bed sores. So for men, condom catheters at night, or women, this new device called PureWick, not Airwick. Airwick is the air freshener, PureWick. Those two things are useful at night.
Are they sized?
For men or women?
Both.
The male condom catheters are sized. If you were to order them from a lot of these products you can actually order on Amazon, and the thing is that the different manufacturers are variable. You really kind of have to look at it and do a couple trial runs probably. The PureWick, I think, is one size.
Harriet, it looks
Kelly,
like you're
you can
muted.
take it away.
Oh, okay, great. We've got one question in the Q&A. Can a suprapubic, I think it means probably suprapubic tube,
Mm-hmm.
I think is what is meant, be used for intermittent catheterization versus being constantly hooked up to a urinary bag outside the body when or when not?
Hey, it's a great question. So remember, if you remember what I said about if you remove the tube, and it's not really a site meant for sliding it in and out, but you can leave the tube in place and put a catheter plug in it. So you only have, you know, a little bit of tubing hanging outside the body and not hanging to a bag filled with urine. And I have many patients who do that, and then they drain it routinely. They do it, you know, go the commode and drain it every 2 to 3 hours. And that works out just fine. Keeping in mind, however, if you do it that way and don't have constant drainage, you may have urine again, potentially leaking the path of least resistance, which is through the urethra. But it's a fine way to do it.
Great.
If you do that, I would suggest though, drainage to a bag at nighttime.
Great, thank you. Over to you, Harriet.
Okay. What about tibial nerve stimulation for a neurogenic bladder? Is it successful, likely to be successful? How do I find somebody who knows what she's doing if you think it's a good idea?
It's another very good question. This is a great educated group. Okay, so I would say to you, tibial nerve stimulation is not widely done. It's not widely recommended. It is in the armamentarium. It is something that could be tried, but it has variable results and not consistent results. So I'm not real big on recommending it. There are, I'm sure, some people who wholeheartedly support it. I'm not one of those. It's just not consistent enough for me.
I'll yield the floor unless we have somebody else in the queue.
Great. We had a number of folks join us a little bit late. And so I'll also mention that you can put your questions into the Q&A, or you can hit the raise hand button. And then I can give you camera and microphone privileges. So maybe we want to turn it to you, Harriet, and then I'll see if any more questions come in.
Okay. If I self-catheterize now, is it likely going to last me forever, or does this stop being useful?
It's a great technique, and it continues to be useful, and it is a good technique to keep you independent without a tube and a permanent nature. The time when it become more difficult would be if you had trouble with your hand function. And in that situation, perhaps a partner can help do the intermittent cath. We have many people who have their partners help with that.
Is it harder for a woman to intermittently catheterize herself than a man?
I would say it's about equal. The folks that say to me, there's no way I'll ever be able to do this, really surprise me. There's some people who you think are going to be able to do it without a doubt, and they just can't. I kind of think it's you know, going to the analogy of the gentleman who talked about the glasses, I think it's like contact lenses. Some people can pop them in and out, no big deal. Some people who are very savvy struggle with contact lenses. It's just variable.
Thank you. We've got a question that came in through Q&A. Do you recommend Botox along with intermittent catheterization?
Another great question. Botox is a you know, I talked about all these medications. Botox is a great potential for people. And basically what Botox does is it paralyzes this portion, a portion of the bladder, not the whole bladder, but it paralyzes a portion of it temporarily. So just like when people have, you know, they don't get the wrinkles when they put Botox in their face, they don't have the ability to contract down the muscle of the bladder. And so if you do intermittent cath and you have Botox, you're less likely to have leaking in between. Botox lasts anywhere between 6 to 9 months, so it has to be repeated. And in order to have insurance pay for it, they require you to have tried and failed two of the oral medications. At least that's the current insurance company's comment around the Cleveland area.
Thank you, Dr. Reigle. Harriet, over to you, and then we have one more question in the Q&A.
Okie dokie. What is the difference between a bladder pacer and a bladder stimulator? Is there a difference?
I think you want to consider them essentially the same. The pacer is the one that goes into the spine, the Medtronic's device I talked about that goes into the sacral stimulator, or excuse me, the sacral nerve, and it is stimulating those nerves on a routine basis and pacing it. As far as the stimulator, I don't know if you mean the same thing or if you're talking about the perineal nerve stimulator, which again gives nerve input to try to trick the nerves of the bladder. I think you're thinking of the same thing.
I'll just interject my own question because so there is a stimulator that stimulates the perineal nerves. That's another
No, the
possibility?
tibial nerve. The tibial nerve.
Tibial.
Yeah, I said
okay.
perineal, I meant tibial.
Okay.
Thank you for clarifying that.
Okay, so you think it's the same thing? Okay.
No, I think the question is about the sacral nerve stimulator, is what I think they're asking me. The same thing. A pacer and the sacral nerve stimulator is the same thing. The tibial is a little different in that it's trying to trick the nerve input. It doesn't go directly to the spinal column.
Great.
And as I was saying, I'm not a big supporter of that one.
Thank you.
Great. Thank you. We've got a couple questions in the Q&A that we could probably finish out with. Harriet, I don't know how long your list is, but one of them is, if one gets the suprapubic catheter and chooses to intermittently catheterize, you recommended the drainage bag at night. So does that mean that someone has to lie in the same position all night?
Sounds like a good follow-up question. And so it does restrict a little bit your movement. Yes. If you have a good bag tubing, you can roll around a little bit, but not a big flip flop side to side, or you're going to be pulling that bag off the side of the bed, disconnecting and having wetness. Most of the time, you're going to be pretty close to the same position. Great question.
Great. Thank you. One more. What are the indicators for taking medication for the neurogenic bladder?
Symptom control. If you are having leakage and inability to hold the urine, and you're not retaining urine, that's a great time to consider the medications. If you take the medications, you're having leakage and you can't empty the bladder, then you can take the medications in intermittent cath.
Thank you.
So it's symptom-based.
A question, additional question, Dr. Reigle. Indwelling versus suprapubic catheters, why do you go one way versus the other?
Yes, another good question. So statistically speaking, if you look at statistics, the question is what's more likely to cause problems with infections? For females, the urethral catheter, the standard catheter, is more likely to have infections than the suprapubic. And that's specifically because it's right there at the vaginal canal, which is loaded with normal topical bacteria, much closer to the anus and rectum, much harder to manage hygiene-wise with bowel movements. So infection rate is one thing. Secondly is comfort. For women with a urethral catheter, the problem is that catheters with time, people complain they start to push out or they require more and more in the balloon or they leak around them. And the reason for that is that as you're sitting on a catheter, your body actually erodes a little bit and the opening becomes bigger and bigger. And I have had some patients where with a chronic catheter, you have to put, instead of 10 milliliters in the balloon, you have to put 50, 60 milliliters to make the balloon just bigger to hold it in place. I've had some patients where the urethra erodes so much, you can place an entire thumb into the urine channel, the urethra. So erosion and infection are two of the common reasons for women that we make the conversion over. For men, the difference is the penile catheter. The comment about erosion, you can similarly have an erosion in the urine channel where all of a sudden the opening erodes all the way down to the mid shaft of the penis. And they call that hypospadias, and they call that traumatic hypospadias. So that the opening is actually at the mid portion of the penis rather than at the tip, because the tube itself has put so much pressure there. So that's one thing. The second thing is that the urethral catheter in the male goes through the urine channel and also through the prostate and into the bladder. And so that can add some prostate irritation and potential for prostate infection and bleeding. Some people have, as time marches on and as we age, the prostate enlarges. And as it enlarges, it gets a lot of blood vessels on the surface. And those blood vessels can ooze if a catheter is running through them. And it can cause a lot of problems with bleeding and clogging of the catheter with blood. So for men, sometimes the urethral catheter just becomes too difficult to manage because of that. And then the conversion is made over to the suprapubic tube. The delay on the suprapubic tube, the reason a lot of people don't opt for that in any great rush is that it is a surgical procedure. And surgery is surgery. And make no mistake that problems can happen. It's, in my opinion, it's a very safe and well-tolerated procedure for most people. But when you have to give an anesthesia to somebody, there's always a potential for aspiration or complication anesthetically, or bleeding complication, or many other things, of course, infection, etc. So it should be taken very judiciously and very, with a team approach to really say, is this right for us? What's the risks and benefits? And as a family, is this something we can manage? And I think that's one of the most important things. This is not a disease that's an individual disease. This comes down to, how is your family going to manage? And what does this mean? And can we travel? And can we ride in an RV? Can we, ride in a van? Can we do X, Y, or Z? Can we stay in a hotel? Can we swim? Can we go in the ocean? These are all questions. What about caregiver? What if things deteriorate? Who can my spouse take care of this? And if my spouse can't take care of it, can my child take care of it? There's a lot of nuances to this, and it should all be taken as a family in great consideration.
Thank you. I
Thank
want to
you,
acknowledge
Dr.
that we're-
Reigle. I see Jerry's hand up, and since he opened the hour, I would like to have him have the final word. I hope it includes tremendous thanks.
So the question about moving around in the bed with a bag, the night bag, what we have found is Marlene was sleeping on the right side of the bed, and I put the stabilizer on her right side. And there are different night bags that have length of tubes. And we found one that was long, I think it was 42 inches, where she was able to move around. So we could still hug when we were in bed. That's just my comment. But I really thank you very much. I'm sitting here, I'm impressed with all the knowledge that I knew you had, but you just rattled it right off, and that's great. And I thank you very much for doing this.
We are forever in your debt for giving us this hour.